Thank you. Hello, I'm Shelley Fuller. I think most of you know who I am. I just wanted to start with an acknowledgement of country and recognise that we're on the lands of the Yurraga and Turrbal people, and pay my respects to elders past, present and emerging, and recognise that actually we need to be careful when we think about artificial intelligence, particularly when we think about Indigenous perspectives, because it's going to pull the data and potentially really normalise those Western views even further. So it is something that I work on with a collaborative actually around some of this work. I'm very excited though to be able to introduce Amalie, who is going to be talking to us about integrating artificial intelligence in public health. And I've learned a lot because I've heard Am talk a few times this year around this work. And it is really cutting edge. It is where we need to go. Am really brings a really nice perspective to thinking about this work. So Am, over to you.
Thank you. How to follow that intro is a lot of pressure now. Thank you everyone for having me. I am here to talk about how we can integrate AI into public health practice. So I have had a number of requests this year to go and talk about this topic to a lot of external providers, and so I thought it might be useful for us here at the school. So I too would like to start by acknowledging the traditional owners of the lands on which we meet today. So for us, it's the Turrbal and Yurraga people, and pay my respects to elders past, present and emerging, and extend a welcome to any Aboriginal and or Torres Strait Islander colleagues or students that are joining us today. I would also like to reaffirm my and the university's commitment to diversity and inclusion. So diverse perspectives, abilities, experiences and backgrounds inspire creativity, encourage innovation and enrich our communities. Members of our broad community are valued and respected for their individuality, and UQ strives to create a culturally safe, welcoming and inclusive workplace with strong community connections and partnerships. And I hope some of that will come through in the work. So I wanted to start by sort of explaining how I came to be here in the weird and maybe a little bit scary or apprehensive world of AI. So I started out as an infectious disease epidemiologist. I still am an infectious disease epidemiologist. So I did a Master of Applied Epidemiology at ANU, followed by a PhD in epidemiology. And so the themes of my research were really surveillance, outbreak investigation, and vaccine uptake, particularly in adults within Australia. But following my PhD, I got a job with the Australian Institute of Health Innovation in Sydney. And that's really one of the key research organisations in Australia that's leading the way in digital health, less so public health, but digital health. So I had the opportunity for 3 years to work with a team of primarily computer scientists, and I had a real crash course into digital methods and AI. And maybe I should have left it there, but it sparked an interest, and I felt that perhaps I was learning something that not everyone else understood. And so this was a good opportunity for me to learn something that I could then, impart knowledge to other people in public health. And so since that time, I've been really trying to figure out ways that we can better use these methods, including AI, to integrate into public health practice. So I wanted to start by talking about how we started in digital health, because we are in a sort of a new frontier. We're in the middle of a very disruptive technology with large language models, so things like ChatGPT. But we do have a lot of evidence from past digital interventions and digital sort of disruptions where things have been replaced that we can learn lessons from. So certainly understanding some of the history when we're in this space can be really helpful when it feels like we perhaps don't have a direct path forward. And I always like to put this one in. I feel that perhaps in 2020, what are we in, 25, 26, 26, 25? Yeah? Right. That maybe people are starting to associate my name a little bit with AI. And I'm fine with that. Please, anyone, if you have questions, come and ask me. If I don't know, I can likely point you in the direction of someone that might be able to help. But I am not necessarily pro-AI. And I think that's really important. I mean, here, but especially when I go out and talk to people in public health units or other people on the ground, because there is a lot of apprehension around this type of technology. But I'm very pragmatic, and you can see here that when you look at all the different sort of forums where people have taken the time to reach 1 million users, ChatGTP, when that was introduced, was really faster than anything else. So we're in the midst of a very disruptive technology with huge commercial interests. And so I really want to understand that, so it's not happening to me, but that we can be part of the conversation. And so before ChatGTP came along, I kind of felt like I was starting to know a little bit what I was doing. I understood the main machine learning methods, and I had, was feeling a little bit more concrete. But the last 3 years have been a very steep learning curve once again. So where are we now with AI? Did anyone see this video of the bunnies jumping on the trampoline? A few people maybe. So this did the rounds. It went viral on YouTube. It was a bunch of bunnies jumping on a trampoline. And then about 3 days later, it came out that this was AI generated, and the whole internet just, went into meltdown because they were so sad that this was AI. I know this isn't health related, but I really just want to show where we're at. Like, this is the capabilities that we're now seeing are very different to what anything we saw even 5 years ago. When we look at health specifically, there are some newer applications. So these large language models, which are really at their very essence, algorithms that predict the next most likely word at a very basic level. We have the large language models like ChatGTP, Bard, the Copilot that a lot of us are using. But what you can do with these models is fine tune them, which means that you can make them more efficient at very specific tasks that you want them to do. So this has actually meant that there's been a number of specific medical large language models that have been developed. And as you can see here, they now are very comparable in the medical licensing examination in the US when compared to humans. So there's a lot of power within these large language models. There's now also publicly available general large language models. So I guess one key thing to think about or to understand for public health when we think of privacy is things like ChatGTP and these open AI systems. Everything you send goes to a cloud, goes to a server somewhere. So you're giving that information to another person. What these general LLMs mean is that they have open source code. So imagine you did a logistic regression in Stata, something very basic, and then you publish that and said, this is my code, other people can use it. That's really what Llama is. They've published their code so that then people can build their own large language models. So you can actually build a large language model on your own machine so that the data isn't going anywhere. You do get into issues with computing power very quickly, though, when you do that. So there's also issues. So we have cloud-based and also local systems. What I would like to do today, now that we kind of know where we are with AI, is talk through a few key examples that my team's been working on to kind of try and explore this space. So some people may have heard me talk about this project before because it's been going for a little while. But the first thing I wanted to talk about was using AI to strengthen infectious disease surveillance in general, but also specifically at mass gatherings. So our aim really is to use new data sources that might be publicly available. So things like Google Trends, Reddit, there's been discussion of crowdsourced data to see if we can then use these new data sources in conjunction with machine learning methods to act as a syndromic surveillance system to detect outbreaks or increases of disease in local areas. So that's really what we're trying to do. We're working in collaboration with a number of public health units across Queensland, and the request was that we focus this on gastrointestinal and respiratory diseases. So that's what we're focusing on. And my real dream is that we could get this up and running and be able to hand it over to Queensland Health so that this could be used during the 2032 Olympic Games in Brisbane, but it also has implications for use in routine practice as well. So the proposed system would have combined data streams. So does everyone remember Google Flu Trends when it first came out? And it was a big nightmare and everyone said we can't do that anymore. There are a number of issues with that specific surveillance system, which we've learned from. One of the big things was there were a lot of assumptions within that data and that modelling that was never made publicly available. But they also didn't consider how highly susceptible these kind of data are to media influence. So if we're using something like Google Flu Trends and Rihanna gets flu, we're going to get more searches around influenza, and that doesn't necessarily mean there's an increase in disease. So there are some considerations. But what we are hoping is that this can be used for routinely collected data. It could be almost real time while we're scraping data. Hopefully that it might be able to detect disease trends more quickly, and that it could be scalable. So those are really the main aims, to give a surveillance system to the state and to Australia that will be faster, flexible, and able to use routinely collected data. So far, first of all, there are systems like this running in the UK and the US and probably other places I don't know about. But we haven't really done a lot of this work in Australia. So the very sort of first pass, we decided just to use one data stream to see if there was any correlation between Google Trends data and our notification data. So we had a number of search terms from Google Trends. We use clinical search terms for this. So we didn't use general population search terms because there's a lot of information in the literature that suggests if we use clinical search terms, we're going to reduce some of that noise that's impacted by the media and different things. So we had weekly notification data from the notifiable disease surveillance system. We had weekly Google flu trends data, and we had 22 different keywords. And then we used a number of models, and you don't necessarily need to understand all of these, but these are very sort of standard machine learning models. So elastic net regression, support vector regression, random forest, and feed-forward neural network. And I would say on most of the projects that I work, these are some of the standard models that people will start with as a baseline to see how it's working, and then people would further refine from there. So we use sort of very standard ones to check. And what we wanted to see is, can we detect increases of disease for this exact week, for 1 week ahead, and then a week ahead of that? We use different evaluation metrics. So this is where a lot of your key epidemiology skills still come into practice. There might be someone doing the modelling, but thinking about the input data and how that might be interpreted and how we should be measuring it remains incredibly important. So we used mean absolute error, which is really how far our prediction was from what really happened. We used a Pearson's correlation, so how close was this? And then we actually started with just those two measures and then realised we needed to be a little bit more comprehensive. So we put in peak week and peak magnitude differences, which is not just can we detect a peak, but is it in the right week? And is that peak at the same kind of magnitude as our prediction? And this is what we found. So this is for Queensland, and this top bit up here. So we've got nowcast, so that's the first week, 1 week ahead, and 2 weeks ahead. You can't tell much. This is kind of a descriptive study, but what I will say is that the elastic net overall showed the best predictions. And when we're looking at MAE, we want a lower number. For all of these, we want a lower number, apart from the Pearson's correlation, which is saying how close is our assumption. But we found in general that there was a correlation and we could predict some of this. And then we looked at this across states. So these are the nowcast. So nowcast is this week, and we have the different states. So we've got the Pearson's correlation coefficient on the side here. So that's the one where we want a high number. So the closer to 1, the better that model is. And what you can see here is these all these crosses on this side are really the biggest states. So New South Wales, Victoria, and Queensland, which in hindsight probably should have been very expected from me. So bigger data means that the predictions were were better for those states. And then not so great for some of the states with smaller populations. But again, this was a feasibility study, and so it was just to see if we could do this. We learned a lot of lessons. I don't know if this is my most successful project, but I learned a lot from it, and I feel like it's been a good jumping off place. So we learned that the models perform better in larger populations. So while we were trying to minimise noise by using clinical terms, perhaps in the Australian context, where we don't have the same population as in the US or the UK, we might need to be exploring larger search terms and then finding other ways to deal with that media noise. We found that they can forecast influenza up to 2 weeks. Now, again, this was one data source, and 2 weeks is certainly not the maximum. There's other modelling studies in Australia that have shown that we can get 4 to 6 weeks. So again, just framing this as a pilot study, as I don't have heaps of funding for all this yet. So a lot of my work really is feasibility. So we don't have the most advanced prediction, but we can predict. And that we did notice that there were regional keyword differences. So this might need to be specifically tuned depending on which state or location you're in. So we might need to use specific data from each location to train the model. Because with public health action, we did this at a state level for feasibility, but what we really need to know is about information at the local level, and that'll certainly be our next step. So what we're doing this year with an enabler grant from SPH is now looking to see whether we combine data streams. So all the international literature tells us that one data stream isn't so great, as with Google Flu Trends and other examples that have come out since that time. So if we combine a number of data sources, which are all biased in their own ways, we get better predictions. And now I think the other thing to think about with this is with AI and this kind of more general kind of analysis, this is fit for purpose. So we don't necessarily need things to be completely accurate for syndromic surveillance. For syndromic surveillance, we're looking for a flag that then can lead to public health action for people on the ground. So this might not be the best method for something else, but for this specific aim, it actually meets those requirements. So now what we're in the process of doing is using Google Trends and Reddit data to see if we can improve those predictions when we use more than one data stream. The aim would be to have about 4 different data streams to build a more robust model. And then at the moment, we are still comparing against the National Notifiable Disease Surveillance System. This is very open for discussion if anyone has any ideas. So I'm planning to put in an ideas grant for this project next year. And it has been pointed out a number of times that that's perhaps not the best gold standard for us to be comparing to. So we might need to have some kind of, serosurvey or some other kind of survey to validate these findings in a larger kind of study. Oh, and we're also doing a review. So we've been using our own prediction methods based on expertise from other people in the university with AI experience in prediction. But we're also in the process of finalising a review, which is looking at which methods have been most effective in this kind of system so that we can then apply those. So that's surveillance. That's what we're doing in that space. And I think the good thing about that project is that a number of the investigators are actually from public health units around Queensland. So I think I originally went to one of my colleagues and said, this is my idea. And it was about enhancing notifiable disease surveillance. And they said, no, don't do that. That's rubbish. We already have enough information from NNDSS. But they said, syndromic surveillance is really an issue. Can you do this? So having that kind of feedback all the way through is really important. The second thing I want to talk about is one of my PhD students' work. So I don't know if anyone here knows Jovenel, but he's working on artificial intelligence for enhancing public health outbreaks. And this really has even less kind of work in the literature. So I do feel for him. He's really forging the way. We don't have a lot of results yet, but just to let you know, the first thing he's doing is building using large language models to see if we can generate hypotheses for an outbreak investigation. So for anyone here who's not an epi or an applied epidemiologist, one of the steps in an outbreak investigation is that you would get food histories if it was a foodborne disease, and then you would collect that information and you would start to generate hypotheses that you could then use for more of a quantitative study, like a case control or cohort study. So we wanted to see if that initial kind of hypothesis generation could be done by large language models. This bit isn't so popular because some of our colleagues in public health like doing this bit. They didn't want to take it away. But we're just investigating and learning as we go. I think one of the main aims in my program is not just the work, but it's for us to understand this technology better so that we can then share those learnings. And then the second thing that Jovi's working on is the development of a large language model powered chatbot. I really need to change that. So I've learned a lot. So you're not allowed to call them chatbots. If a chatbot is a very static kind of machine, so I could program that, with my programming skills, I could say, if someone says this, then say this, and it's got a standard response. Whereas these AI enabled are much more conversational and able to change their responses based on the input that they receive. So we call those AI agents. And what he's really doing is trying to build a model that we could send out to people and then we could get a food history. So if there's an outbreak of some kind of foodborne disease, when you're working in a public health unit, you usually call people and then you say to them, what have you eaten for the last 7 days. And they usually don't want to talk to you because they want to tell you it was the chicken they ate half an hour before they started vomiting. But you know, you kind of have to keep pushing through. And so we're going to compare that to human interviews and see if we can get something comparable. And we'll be testing that with volunteers. So this was originally supposed to be integrated into a public health unit. But one of the things about AI in public health, which I think Jovi's online and would back me up with this, is, and no one believes me, but I'm just going to keep saying it, like 20 to 30% of the work is around coding and the algorithms and the models. 70 to 80% of these kind of interventions fail because of something we call human-computer interaction. So there's a whole space in digital health, which we call human factors, which is investigating how we as humans interact with students, interact with the machines. And my favorite example, and I'm sorry if anyone's heard this before, is a colleague of mine, Mel Baysari, who's based in Sydney. She goes around and she evaluates different systems. And this was a long time ago, so it doesn't sound so cutting edge now, but there was a reminder system it was a decision support tool in a hospital. So it was on a computer and it would say, okay, I'm going to give this patient this medicine, and then a pop-up would come up if it was like counterindicated, so contraindicated. And so this was in a hospital, and she evaluated. So she followed the people around on their rounds. So she's following around a team of doctors, and it was a teaching hospital. And there was a senior physician and then a bunch of other people. And the most junior person in the team had the computer. And while she was following these people, an alert popped up and said, this is the wrong medication. Don't use this. And the very, very junior person went, ignore. And then when she spoke to this person, they said, you know, that person's very senior. This is my first year as a doctor. I'm not going to, in front of everyone, say, I think you're wrong. I just assume he has more information. So already we can see there was a system that worked. It had been validated. It technically was correct, but people will find workarounds or not use things if they aren't going to be helpful or if they don't trust them. So this is where we in public health can really step up, because 70% of this work, and that's really, if you read some of the digital public health textbooks, they're not great yet, but they still help because there's nothing else out there, so I cling to them. But yeah, 70 to 80% are falling over because of this interaction. So like with any technology, this has some wonderful possible opportunities, but it's about how we actually put it into practice. So if you're working somewhere and someone comes to you with a fancy new idea and says, I've got this app here, this will work, it's going to be great. My hope is that we can all build capacity to start having some of those conversations so that you all feel enabled to ask questions and say, but how will this work? How will it work into workflows? What about ethics? What about privacy? Yeah, so there are a lot of things that you as public health individuals can really contribute to these conversations. And so watch this space. I think over the next few years we'll have some results from this. And to be honest, if you have questions about large language models, go and talk to Jovi instead of me. Like I've been upskilling, but I have a lot of other things, whereas Jovi is doing his PhD. So he's spending most of his time embedded in this world, and he really does already know more than me. And then the last thing I wanted to talk about is something that's a bit more around human factors. So we've done surveillance, we've done outbreak investigation, and then the last sort of theme in my research is vaccination. So I wanted to talk about some work we did, which is looking at the credibility of vaccine information in large language models. So some of my previous work has looked at the different effects that information exposure can have on people. So if they're online, how does that actually affect what people see? Does that affect the behaviour and the attitudes and belief? But now, obviously, information is coming in a very new way with these large language models. So because we have this new sort of function that people are going to be using, we wanted to look at if that information online that people were going to be accessing was actually relevant and appropriate. So we did a cross-sectional content analysis We drew questions from existing literature, so general questions from vaccine hesitancy surveys, and also we included some more conspiracy type questions to see how, if these models could be led. And we looked at these across a number of these, so Google, Bing, Bard. We looked at a few different versions of ChatGPT and Claude AI, and then compared them. So what we did in this study was we used the Discern tool, which is really something that's been very useful up until now for my work, which is a tool that helps you evaluate the accuracy and usefulness of health information online. And it's really all we had at the time. We thought, let's use this. And then we also looked at a reading score using the Shell editor, which is an editor developed by the University of Sydney, which you put in a bunch of text and it will tell you the reading level. And this is really important because there were reviews, particularly in COVID, that showed most of the information on our health websites was aimed at much too high a reading level for it to be useful for people. So there were some issues with communication, a lot of the time, but also specifically in COVID. So that's what we plan to do. This is a list of the questions. So basically, we developed this list of questions and then we put these into the different large language models. There were considerations around that. We had to bring up a clean page every time to stop any learning from before. So there were some considerations, but this is what we plugged in. And then 3 people each reviewed the answers against the Discern criteria. And then this is what we found. So overall, so if we look here, this is overall quality. Red is large language models, Google and Bing are more of our traditional search engines. And really what we found that they were quite comparable. But the real differences come when we look at the different aspects. So if you look at something like clarity of information recency, that's when Google and Bing did a lot better. Also, when we look at clarity of sources, so some of those really important things, such as where is this information coming from when we're thinking about accuracy, were much better in traditional search engines. But then when you look at relevance of information, so this one up here, our large language models did better because that's exactly what they're programmed to do, to give us a very relevant answer. And so there were a few things that we learned from this, but they generally both perform okay. And the good news is even when we put conspiracy type questions into large language models, they still come back with very balanced information. I guess one thing to consider would be that there are now different large language models coming out from different people that may not be so right-leaning. So all of these kind of systems are built on whatever their training data is. And the different, I can't think of the word, but the different guidelines that sort of hold, the rules that are given to the large language model when they perform. And maybe not everyone will be as responsible as ChatGPT. Looking at Elon Musk and his what's that new one called? Yeah, I haven't even looked at it because it makes me too nervous. But certainly for the major ones at the moment, they look okay. But we also found that maybe these tools like Discern are no longer relevant and we need something that's more appropriate for these new kinds of methods. Oh, okay. And then, so now what this work has turned into, this was just in English and I presented this at a national forum last year maybe. And some colleagues from University of New South Wales came and spoke to me and said, what about for people who speak languages other than English? This is English-based. How would this work, especially for perhaps migrant refugee populations in Australia, who some of those populations have higher rates of vaccine hesitancy? And so we now have a collaboration with UNSW and through some swings and roundabouts, a wonderful team from the University of Auckland who are planning to redo this work, but looking at different languages and also looking at how people are actually engaging with this. So not just is it accurate, but how are people engaging with this information? And certainly that looks like it's different across demographics, particularly age. So I don't have any information about that, but that's our next plan. The reason that that's important is, I think as Shelley was saying at the beginning, is the equity piece. And so quite often when I go to seminars or different places to talk, I'm quite often the only public health person there and a lot of machine learning people next to me. And they are wonderful, like lovely people. But one thing, my biggest concern is that equity is rarely discussed. And when I first started on this kind of this journey, I can't remember if she's a professor now, Associate Professor Lisa Watt from ANU. She's a very inspirational Torres Strait Islander researcher who's based in Canberra. And we were sitting down talking about both of our work, and she really sort of donged me over the head and said, you need to think about equity from the very beginning. She said, when a new space like this opens up, there's so many gaps that people don't know where to start. And so people start plugging gaps that are easy. And then 10 years later, people start to think about equity. So that's really where I see my role and the reason that I keep talking about this, because when I go to lots of conferences and things, it's not something I necessarily hear a lot about. And then I just wanted to talk about AI and evaluation because there are some issues currently. So at the moment, we don't have public health interventions that have robust evaluations or even robust implementation. So it's hard to get an exact figure. It differs by different reviews that I read. But I would say as a guesstimate, somewhere between 70 to 90% of tech that is developed is not then implemented into practice. And I really believe that the way that we can fix this is by developing these tools in collaboration. So every single project I have, I work with people who will be the end user at the end so that they can pick up issues early, but also be engaged to help to try and understand it and be less scared when they actually use it. A lot of evaluations are short post-term. There's not a lot of real-world assessments. And yes, there's not a lot of sustainable implementation. So what I will say about this is it's starting to change. When I first started in this space, I used to read a lot of bad articles that made me really sad, and that is really changing. There is a bit of a groundswell at the moment. There's a new journal, so we have NPJ Digital Public Health, whereas up until now we've only had NPJ Digital Health. So I think there is a groundswell, but I also think there's a lot that we can learn from digital health. So I think there's a few things. The US is probably about 10 or 15 years ahead of us. CDC, before the badness, was a real leader in this space. They had a public health informatics officer training program, much like the epidemiological intelligence program. And so I think we can learn lessons from overseas, but I also think that we can learn lessons from digital health. So we have the Queensland Digital Health Centre here at the university, and I work with them one day a week. It's very much, it's similar to the difference between medicine and public health. Everyone thinks it's very similar, but it's very different. And so I think there are lessons, and I love sitting over there because, I'm really getting to work with a lot more people who have expertise in this space. So I think there are lessons we can learn from digital health, but we really need to start putting our own public health spin on it, because the conversations that I have are probably not the conversations that I would have here if we were talking about the same kinds of interventions. And so the last thing I wanted to leave you with is that there are a few different frameworks if you do have some kind of AI, some kind of digital technology that you can use. So there's a lot of different literature out there that you can use. I've bolded the two that I use the most. So if you're stuck and you just want to look at something, a digital kind of intervention, even when you're planning, I would highly recommend both of these. They're kind of my go-to. Every system you do. Look, full disclosure, it's a hard space to work in. Everything's always changing, and it can be a little bit overwhelming. But I use these as my base, and then every project, as with anything in public health, has to be very context specific for your project. So the large language model one that we're doing at the moment, we're actually going to be using 3 different evaluation tools. So last time we used a Discern. There are now kind of a proliferation of different sort of AI measurement accuracy tools, but we don't know which ones are best yet. And so for that project, we've decided to just use 3, so then we can actually help with that validation process. And that's all I had to talk about today, but I'm very happy to take questions. I would just encourage you all, you don't have to run out and grab AI. But I would encourage you to ask questions and not be afraid to have conversations if people start to talk about new technology in a space. Just get really comfortable with asking stupid questions. I do it all the time and no one's ever gotten angry at me. People are very happy to usually talk about and explain things. And it's also hard to find the right collaborators. So maybe come and talk to me first and I can send you in the right direction instead of going out blindly. And certainly this is, a lot of people have put work into all of these different projects. So I'd really like to acknowledge all of those. Certainly I'm here talking, but it's certainly not all of my work. Thank you. Does anyone have any questions? Yeah.
The general question. Thank you very much for the information. Thank you. Thank you very much for the presentation. I have a kind of general question, which might be related to the evaluation section of your talk as well. So AI depends on the data which is available, and usually it's based on a huge amount of data for a decision. So especially for health, is there any steps for filtering the quality of the data? Because some of them could be significantly affect the out. Is there any trend for filtering the quality of the data?
Yes.
Some, for example, credit for different source of data we have.
Yes. It's a really good question. And again, and maybe usually what I try and highlight when I give these talks is that everything you already know still applies. So there are all of your epidemiological or whatever area you're from, sorry, I go straight to epi, but all your foundational knowledge applies, which is why we need to be in the room, because machine learning people don't necessarily think about that data input. You know, I'll walk in and be like, but this data is a bit biased. It is hard, like even at the moment, some of my projects are guilty of this. So some of the work we're doing next year is using the IMR data from the digitally enabled hospitals, and that is not yet representative. It's very urban centred. Hopefully that will change over time. But usually those questions aren't even asked. People just get really excited and go, look at this cool new toy. And we're not considering those things. One of the things, we certainly can fix that information. So when you saw some of those, the medical specific large language models, so that comes from fine tuning. So Joby knows more about fine tuning than me, but basically there's a way that you can change the weighting. So when a large language model learns from everything on the internet and then it comes out, it doesn't bring all that information, it just brings its learnings, which we call weightings. And then you can change those weightings to be more specific to your project, which is what we call fine tuning. But the other thing that you can do is retrieval augmented something at the end. We call them RAGs. And it's basically you feeding information into a large language model and saying, I only want you to consider this. Don't consider all the information in the world. This is what I'm interested in. So there are certainly ways to make things more specific. But I would argue that even no matter how, there's going to be a lot of testing and validation before you put these out anywhere, because people are nervous. They don't necessarily trust these systems. And that's our other big issue, is trust. So we can build the best validated model, but if people don't trust it, there's actually a whole section here at UQ that just deal with trust with clinicians and how to explain AI to clinicians. Because if they don't trust it, they won't use it. But yes, certainly you can make things much more specific. Yes, Steve?
Just an interesting, the impact of this on clinical practice. I'm tending to see clinicians consulting Google type sources for diagnostic and treatment reasons, more so than ever before. So if they get something they're not sure about, they'll plug it in quickly and say, yeah, this is what's happening, or possibly. And I'm wondering if there is an opportunity to test clinical suggestions that come from AI against clinical guidelines that are developed by, let's call them experts, is what they are.
So I can't say whether they've been validated against clinical guidelines, but there's certainly some papers that have been in Nature recently or last year that are doing this exact type thing. And even in the earlier models, so some of the things that we've heard about, not today, but previously, things like hallucinations, those are decreasing. Like these models are going to improve over time. So referencing is less likely to be hallucinated, but there's still other hallucinations. But even in the very early stages, they did some of that and they compared a clinical diagnosis from ChatGPT or another large language model with clinicians, and the AI was more accurate and more empathetic.
And would you talk to clinicians about that and say to them, this is probably better than your best guess?
I think that that's a very long conversation, and I think, like anything, it would be the way that it's rolled out. I think it might be okay. Yeah, look, I think there's a lot in that. So there are a lot of risks that come with these kinds of tools. So even before large language models, one of the big safety things when we talk about decision support is overuse of automation. Maybe I can use this here because it didn't go down well in my epi class because no one knew about navigation systems. But one of the things we know is if we don't know what we're doing, we are more likely to heavily rely on a technological advice. So I had this lovely picture when I was teaching of this person who had driven, halfway across Europe because they were following their navman. When we used to have navmans in the cars, and they just kept following it blindly, despite obviously going in the wrong direction. So because people don't know where they're going, they're more likely to trust it. If they have knowledge, they'll use it as a guide. Whereas they'll go, okay, it's telling me to go that way, but I know there's usually traffic there, so I'm going to go this way. And it's the same thing in any application, including medicine, where if people don't know what they're doing, then it becomes dangerous. These should always be used as tools. I mean, there certainly are algorithms that are going to start going through the TGA that will be very specific and they'll be monitoring over time. But it's a very big question.
I suppose. Basically a researcher these days, and I'm thinking of a research paper as I do, and I can see quite interesting research paper where you pick a diagnostic outcome that is interesting and important, and then you compare different language models.
Well, if you're interested in exploring that, I have a GP who's very interested in that space that I can link you in with.
No. Looking for research. Looking for research idea.
Yeah.
More than actual work, but it strikes me as essentially a compelling topic. Is the extent to which there may be agreement and disagreement. It's a standard kind of issue.
Yeah, comes down to prompt engineering. Whatever you put into the text, actually into the model, actually changes what you're going to get the output. It depends what model it's been trained on. It's a lot of, so honestly, I think there's like 50 years of research within all of this for a lot of people, not just for me. And so one of the things that I think I find challenging is how do you start? Like, where's the small space to start in that? So I'm starting with my area of expertise, but I think there's probably things that we haven't even thought of yet in terms of how this might be applied.
It's changing so fast, isn't it?
Yeah, we do have, Ross Andrews, I think, Shelley, you've talked to him. So Professor Ross Andrews leads the Public Health Intelligence Unit, which is really doing a lot of this type of work to see how we might be able to use analytics. And the Public Health Association of Australia is actually planning a 2-day meeting to talk about AI in public health next year. So I think there is starting to become some national leadership. But we just need to acknowledge that this is going to be a slow process, which I've kind of learned. I think at the beginning, I felt really panicked all the time and I felt like I had to do everything. And now I realize this is going to be a long haul that we all just need to upskill and work together to try and figure out how to best implement this for the best changes. Yes, Shelley.
Maybe it'll come to a question. UQ is actually doing quite a lot in terms of the AI space. So we're actually going to get a framework that's going to get rolled out next year. And it's going to cover all domains and the work that we do. But it's going to be a living framework because it's evolving so fast. Anyone who's heard Jason Lodge speak, he's phenomenal. He's an educator. And he talks about we can't not get involved with this technology. He goes, the hardest part is how do we teach people to embody it, because they're going to have bigger brains than anyone has ever thought possible. So the information is going to be immense. So he's talking about that across every discipline that we do. So he thinks that's a large, complicated, complex area that we need to navigate. So just bigger UQ picture there. I've worked with computer scientists around the large language models, machine learning, etc. And it is really hard. And so you start a project and you think, this is what I'm going to do. And then you get to the end and you go, that took me way longer than I thought it was ever going to. And so we had a project where we thought we were going to deliver an intervention and do a pilot RCT, and we just couldn't get there.
Yeah.
We're at that phase now, and it took 3 years to develop it. We've just had to hire another person to basically rewrite the language, because the language we used is now obsolete.
Yeah.
So it's really challenging.
Yeah, so
Really
Jovi
trying to
put
slide.
together a project proposal last December for one of his projects. And then we got busy with some other work within his PhD. And then in July this year, when he revisited that project proposal, he came to me and he said, I have to rewrite so much of this. Things have changed so much. And so when I first started in this space, you know, I would have like a 3 to 5 year plan. And now really you have to have an idea and implement it straight away, or replan when you're going to start it, because it's a scary, not scary, but it's changing so fast. And I think even like when we talk to people in public health units, or there is a bit of, I guess, apprehension, but you also hear a lot, this is going to be obsolete in 6 months. Should you even be doing this? And my argument is, well, we have to start somewhere. And if we keep going, well, it's going to change in 6 months, I'm not going to learn about this. So even though it's challenging, I just keep going. And my main aim is always to, obviously I want to improve public health practice, but honestly, my main aim is just to learn. All of these projects, I think every one I do, I learn a bit more, and that's why I do it. So then I can hopefully come and share that.
There's Genevieve Healy, who used to be in the school.
She's so good.
She's led a big project that was actually out of a teaching innovation grant, and has developed a platform that is really for research in relation to the space. And
Yeah.
we could get her out to come and have a chat to us.
That would be great. Yeah. So she had one of the most advanced AI agents based on large language models very early. Is it called Tara? I didn't have a name last time I spoke to her, but yes. And I would love for the whole university to adopt that, because it's a platform that we could all use then to train AI agents.
It's specifically being built for research.
Yeah. I would love to hear from her. She's actually helped me quite a bit over the last couple of years when I call about AI agents and things.
Is there anyone online? You can just unmute and talk, or write it into the chat.
Nothing?
I have something. Sorry. Can you hear me?
Yes,
go ahead.
absolutely.
Oh, sorry. Hi, Amalie. I love the presentation. I'm with the Queensland Centre for Mental Health Research. I'm not sure if you remember me. We spoke, I think, a couple of weeks ago.
I do remember you. Was that on that? Yeah, we were in a breakout room together.
Yes, we were.
Yeah, sorry, keep going.
Excellent. So we've put in an MRFF grant for early and mid-career researchers, looking at sort of developing a website for young people to get more information about mental health services. And we were looking to incorporate, either a chatbot or, some sort of AI agent to try and help direct, them to depending on their service needs. But obviously we're incredibly concerned, I guess, or hesitant, given some of what's happened in the mental health space with respect to AI. And I'm just wondering if you have any time maybe to speak to us about that, or offline.
Yeah,
or anything,
absolutely.
or
Flick me
anything
an
like
email. I'm
that.
happy to. And I think two things there. I think there have been some concerning instances in the mental health space, but usually those are with people using models that aren't fit for purpose. They're using very large language models that weren't specific. And I think the other thing is, I don't think I'm technically allowed to say this yet. I don't think it's been published. let's just say that I know something, that most mental health interventions with an aspect of AI do not incorporate I don't know, I'm looking at this like that's the person. But most of those types of systems don't actually include young people in the development. And so I think those are probably the two big learnings off the top of my head, but very happy to make it, still doing it. But very happy to make time to talk about that.
Excellent. Thank you so much. That would be great.
Anyone else online?
Great. Okay. Thank you everyone for coming. I appreciate your time. I know everyone's very busy.